Good evening, everyone, and thank you for joining us today. We are excited to have you all here for another wonderful patient webinar. How bad are GLP-1 medications for my eyes? My name is Gabriel Macias, Business Development Manager for Harvard Eye Associates. It is my pleasure to introduce our presenter for the evening, Dr. Brian Kim, Medical Retina and Cataract Specialist. Dr. Kim is a board-certified ophthalmologist who has served the Orange County community for over a decade. Recognized as one of the region's physicians of excellence annually since 2018, he has often been called the physician's physician for his trusted care among fellow medical professionals. Fellowship trained in medical retina at the prestigious Bascom Palmer Eye Institute, Dr. Kim specializes in retinal and macular disease management and cataract surgery. He is actively involved in advancing ophthalmic care through peer-reviewed research and clinical trials at Harvard Eye Associates. A frequent media expert on eye health, he also holds multiple U.S. patents for vision aid technologies, leveraging augmented reality and AI. Dr. Kim, thank you so much for being here to host tonight's patient webinar.
Great. Thank you so much for the introduction, Gabe. This is an exciting topic for sure, seeing as how popular these GLP-1 medications are in the media. And today, this is something that's a little bit out of my comfort zone, actually. So this is something that's not quite entirely retina. It actually expands into multiple areas of ophthalmology. So you'll have to bear with me a little bit as I try to stumble across explaining different parts of the eye that I'm not accustomed to, but I think I can do it. So I appreciate everybody's patience. But again, yes, thank you everybody for joining us this evening. Another patient education webinar, and these people seem to really like these. So thank you again all for spending your evening with us, and hopefully this won't take up too much of your time. So let's get started. These GLP-1 medications are very popular right now, and it's estimated that approximately in 2023, it was about 2 to 3% of the entire US population was on these medications. And currently, as it stands in 2025, it's now up to about 6 to even 12% is of the population. That's amazing. That's millions and millions of people who are taking this medication or these medications, and for various reasons. And I mean, this is something so pervasive into our healthcare system now, and it's now becoming mainstream culture here. So we see this all the time. We've all seen these headlines come up about Ozempic and Wegovy, and those are the two big ones that most people have heard of. A lot of people are using them for diabetes. That's still the number one most commonly prescribed reason for the GLP-1 medications. But we're starting to see, of course, increased use for weight loss and for cosmetics also. So now the biggest question really is are they okay for us, or what are they doing to us? These have been around for just a little over 5 years now. And so we really are now starting to see the longer term effects of them on a broad scale spectrum. So the way that these work are they start to work on the gut, and these GLP-1 receptors are really good at slowing down gastric emptying. So it makes you feel full longer, and we're really able to trick the brain into eating much less and feeling full, which is fantastic, obviously for weight loss. But it also does a lot of other things too. We have these receptors throughout the body and in lots of different tissues. In the lung, in the kidneys, in the brain, and even in the eyes. We see these receptors in the retina as well. But each organ has its own specific response to these GLP-1 receptors, and each one's a little bit different. But all in all, what these can lead to are things like decreasing inflammation overall and decreasing the loss of cells prematurely. And so overall, what we get is, number one is weight loss, of course. That's the one major point that we all see in the news. But the second one being diabetes and better blood sugar control. We typically see this most commonly, and of course, I'm not an internist, but typically we see these used for people who have not had a good enough control with diet and exercise alone, who've tried other medications, typically things like metformin. That's the most common one that we see. And people who have a little bit of a larger body habitus, or are overweight, and we need to lose weight to really control some of our risk factors. So overall, we're seeing this overwhelming response of positive benefits. Not only the weight loss and the diabetes control, but really we're seeing a reduction, especially in diabetics, a reduction in cardiovascular disease risk, so heart attacks and strokes. We're seeing that there's a protection on the kidneys too, so that we're really preventing kidney-related diabetic kidney disease. We're reducing inflammation across the board in all cellular systems, in every organ. We're reducing cell death and turnover. This is starting to come out in the news now, that in research, that we're starting to see this effect on alcoholism, that it actually decreases the demand for, or the desire to continue to drink. So this might have huge impacts on addiction, and even beyond alcohol, maybe perhaps even into other drugs as well. Just now in the news, we're starting to see new headlines where these kinds of medications can even slow or potentially even help Parkinson's disease or Alzheimer's disease and dementia. Um, certain doctors and certain specialists out there have even claimed that it's even causing an anti-aging effect, and probably leading to longevity. Um, so it just seems like this is all positive and positive, and there really just doesn't seem to be too many downsides. We do hear things about nausea and some stomach aches, and things if we're taking it too much or too high of a dose. But aside from that, if we're able to stop that, the people seem to be able to recover quite nicely. So we're not seeing a whole lot of major side effects. It's almost like these are too good to be true. Um, so the biggest question that I have is, what kind of effect is this actually going to have on the eyes? So here's some clips of people who are in the news. Celebrities are using this left and right. Mindy Kaling, Kelly Clarkson, Ariana Grande. I mean, people are using this for profound weight loss. And some people have even seen this sort of characteristic Ozempic face. Even that seems to be one of the side effects of losing weight so quickly, is this sort of hollowed appearance. This is, I don't know. I thought this was kind of a very common thing, but I did a recent office poll, and I guess this is something new to some people. But this hollowed appearance, these sunken cheeks, when you start to lose the fat too quickly in the face, it can lead to signs of aging, meaning sagging skin, and some wrinkles become a little bit more prominent. So we treat that now. As a lot of people and celebrities are getting dermal fillers, and we're doing skin tightening procedures with lasers, and sometimes even just have to do a little bit of a nip and tuck to try and get the rejuvenation back, and to counteract the effects of losing too much weight too fast. We do that here at our oculoplastics department, and specifically Dr. Sears is our cosmetic oculoplastic and oculofacial surgeon. So she does a lot of all of this. And so I'll reserve those kinds of questions and concerns she's going to do a talk on this probably in the upcoming months. But something that's becoming a lot more prominent now that we're seeing 10% of our population on these medications. But really, how does this affect my eyes? And that's what I'm concerned about. As a retina specialist, I want to know, what are the effects when we start taking Ozempic? How does this react with the retinal cellular receptors? So we know it helps to bring in more, to reduce the sugars. It really helps to preserve and prevent tissue death. And in the news, there has been there have been a couple reports. This was one of the first ocular side effects, and it came out as sort of a really pretty ominous sign. There's a big group at Harvard, the hospital there called Massachusetts General Hospital. the Mass Eye and Ear Institute, their neuro-ophthalmology department had done an analysis on all of their ischemic optic neuropathy patients, meaning people who've had a stroke in their optic nerve. And they found out that it was approximately 6 to 9% of those people had recently started these GLP-1 medications. And this led to a huge uproar in the medical community. And it's so bad that here I even have one of this clipping here from a law firm that is even promoting a class action lawsuit against Wegovy and these GLP-1s in reaction to this data. Normally, this ischemic optic neuropathy or strokes in the eye will affect the optic nerve, creating a little bit of damage in this one sector, and that can lead to a partial vision loss that's permanent. Sometimes it can be more than that. Sometimes it can be less than that. But certainly not, and something that's not treatable, unfortunately. But so we want to know really what is the actual risk, because this is something that's rare normally. This is something that's like 2 to 10 people out of 100,000 people. That's rare. 2 out of 100,000 people will end up with this naturally. When we have diabetes, it's closer to the 10 out of 100,000 people. But we really want to know, is it in fact reality? It's a very skewed study, and this is where it gets tricky. And this is why there's all these memes out there and internet jokes about people who quote unquote do their own research, because it is hard, even as a physician and somebody who is versed in science and statistics and engineering. I have a degree, and I did math for for much of my life, and it's still very challenging to navigate the science behind all of these. So on the left here, this is the actual paper that was published in the Journal of American Medicine, of the American Medical Association, and they had quoted that the risk ratio was about 4 times as high in people who have diabetes, and about 7% higher than for people who do not have diabetes and start taking things like Ozempic. That's their risk is 400 and 700% higher than if you didn't take these medications. And that's astounding. And that's something that if you were given that statistic alone and said, oh my gosh, if you start taking these GLP-1s, you're going to have a 700% increased risk of having a stroke and losing vision. That's a profound statistic with a profound weight behind it. But in actuality, this is still a rare kind of thing. And you have to remember that this comes from Harvard. This is something, and subspecialized department of Harvard. So these people are seeing a very skewed population. Their study, you have to keep in mind, is an association, meaning that they're running a statistic based on the association here of ischemic optic neuropathy and the finding that people happen to be on GLP-1 medications. Now, that's very important because association does not necessarily mean causal. And you're going to hear this over and over again over the next few slides, that all of our data so far is about association. And that's how we come up with these statistics. To put this differently, the analogy that I like to use is association is something like an extra large t-shirt. Extra large t-shirts are associated with being overweight, but the extra large t-shirts did not cause people to become overweight. And that's very important how we decipher these, okay? So, so when we really look at the details here, we're looking at a skewed population here of patients who had a slightly higher risk of stroke in the eye. When we did this again, and we did this in a larger scale, including people who just the general population, we increased that data size, and we found that really out of 66 million people, when we analyzed that data, we really are not seeing a significant increase in the risk of ischemic optic neuropathy. So it's very important how we look through this data and how the studies are done. Yes, don't get me wrong. This Harvard data gives us a very interesting snippet as to what kind of data, but we have to keep in mind it's a very specific kind of data. This was published in national news, these numbers. So these are numbers that you might hear again, 7% and 9% risk of having a stroke in the eye or vision loss from Ozempic. So again, take it with a grain of salt. All that means is people are not really drilling down into the data and looking exactly what the risk is, because we're still on the order of 10 in 100,000, maybe a little bit higher than that, maybe 20 in 100,000. So we're not looking at huge numbers here. So overall, keep that in mind, okay? Little bit more recently than that, that was so the ischemic optic neuropathy was the first study that came out, and that was the first thing that heightened us to ocular conditions or ocular side effects. But a little bit more recently, we've started to see in these clinical trials that glaucoma might actually be reduced. Now, keep in mind, we're using Ozempic mostly for people in diabetes, in people who have diabetes. So diabetics in general already have an increased risk for developing glaucoma. So being able to mitigate that risk in diabetes, it becomes very important. We want to be able to normalize that risk and bring it back down to something closer to people who don't have diabetes. So in the big trials, the name of the trial was called the Sustain 6 trial, but it was one of the huge phase 3 clinical trials for the approval of these GLP-1 medications. It actually showed that, yeah, there might actually be a 30% lower risk of glaucoma in people who have diabetes after 3 years of taking these medications. So that's huge. So we're actually being able to treat and prevent glaucoma in a significantly larger larger portion of the population in people who have a high risk. So as a reminder, glaucoma is peripheral vision loss. That's this picture down here, causes the loss of vision from the outside in. And this is a picture of what happens in glaucoma is the optic nerve actually starts to weaken. It thins out and it looks like, gives this appearance of like it's enlarging is what I like to say. So, yeah, but interestingly enough, this is not related to high eye pressure. So meaning that the pressure stays the same in the whole thing. It's just that people are able to sustain, keep the optic nerve healthier for a lot longer. Interesting. We have known for many years, it's been the biggest myth that glaucoma is directly linked to eye pressure, meaning that you have to have high eye pressure in order to have glaucoma. But that's not the case here. Sometimes the optic nerve can be too weak for you and for your eye pressures, and that's the case in diabetes. So if we're able to strengthen the optic nerve in these cases, that's a huge win. So actually, we're seeing pretty good things here on the side of glaucoma. Diabetic retinopathy. So now this is the mainstay of everything. So people who are diabetic, of course, this is the biggest concern. It can be one of the earliest findings that people are having systemic or overall damage in their bodies is diabetic retinopathy. And that's why annual eye exams, once you have diabetes, annual eye exams are extremely important. It's a window into our vasculature to see exactly what kind of damage are these high blood sugars doing. We can actually see that, and the only place we can see it is in our eyes. But it's sort of like the canary in the coal mine. The eyes tell us what's happening in the rest of the body. So if we're seeing diabetic damage in the retinas, that also means it's happening in the kidneys, the brain, the heart, in your peripheral nerves, and every other organ system in our body. So we want to be able to use diabetic retinopathy here as a litmus test, as that initial indicator as to what's happening elsewhere. Now, this has long been studied. We know a lot about diabetic retinopathy. And if we look at these photos down at the bottom, and they're a little bit small, but what happens over time is, this is a picture of the retina and the optic nerve, is we start to develop these tiny bleeds and tiny cholesterol deposits throughout the retina. And as it starts to increase, we can start to get large amounts of damage from bleeding into the retina, which can ultimately permanently damage our vision. So the longer you've had diabetes and the longer it's been uncontrolled, the higher chance you are of developing a more severe or a proliferative stage of diabetic retinopathy. So what we want to do is try to reduce the blood sugars and reduce the risk of developing retinopathy. And we do that by controlling our A1C. Well, as we know, these GLP-1 medications are really good at rapidly dropping our blood sugars and rapidly controlling how much we eat, dropping our weight. If we're overweight, we can drop the weight, and we can really get fairly quick control over diabetes. Now, it's been a known phenomenon since, 1970s, 1980s, when some of the earliest clinical trials on diabetes in the retina. It's been known for decades that if we drop the blood sugars fast, we will oftentimes see a worsening, usually transient, but it's a temporary worsening in the retinopathy before we see an improvement. So, and we see that again here in our SUSTAIN 6 trial. We see that this 76% of people who had diabetic retinopathy at baseline, when we start to drop our blood sugars quickly, we can actually see a worsening in the retinopathy. Now, if we go from a no diabetic retinopathy to a mild, or a mild to a moderate, usually that's not a huge deal, and it's something that can be treatable. But once we start going into the severe or proliferative or stage, or proliferative and even into really bad proliferative disease, it can be tricky to sometimes reverse any vision loss. And it can be a double-edged sword, because we need to get the blood sugars under control. We need to prevent further damage. But sometimes we have to have a temporary worsening before we see an improvement. So, it's a little bit of a discussion. So if you're taking this for diabetes, the overall benefits of reduced heart attacks and strokes, and having peripheral and kidney disease, that's huge. Those benefits are enormous. But sometimes we may want to talk to our retina specialist, or ophthalmologist, or retina specialist, to see what kind of risk do we think we're going to have if we started. If you're starting at a severe stage, we may want to start off on a lower dose. We may want to ramp up our dosing slower with these GLP-1s. It might be worthwhile talking to an endocrinologist and working together as a team. But it's still pretty early. We don't necessarily know exactly all the details of it, but this is going to be more on a case by case basis. So if you have known diabetic damage in your retinas, definitely we want to discuss this with the retina specialist and our endocrinologist before we start to jump in all at once. But okay. And this is sort of the really cool stuff here. This just came out. And I mean, like a couple days ago, where I had to scramble and add a few slides here to this presentation. It just happened to come out right now. But this is hitting on macular degeneration in the setting of diabetes. Again, we have the most data on people who are diabetic, which is why a lot of this talk is focused on people who have diabetes. But this is a huge paper that just came out a few days ago in JAMA Ophthalmology, saying that these GLP-1 medications increase the risk of developing wet macular degeneration if you have diabetes. And it's about a 20% higher risk. And that's huge. And I don't think a lot of people like that very much, me included. And but again, we have to again dive deep into this paper, and it took me not gonna lie, it took me a while. It took me several hours to comb through this data and this papers to really piece apart the details here. A 20% higher risk, though, of 90%, 90 patients out of 46,000 patients. So overall, the overall incidence, meaning how many diabetics actually developed wet macular degenerations, was exceedingly small. And if you increase that risk by 20%, that number is still exceedingly small. So is wet macular degeneration necessarily something to be afraid of or to stay away from these medications? I would say probably not. Again, it's going to be case by case basis. There may be an occasional person who that risk might be higher, but we really want to weigh the benefits of these medications overall on diabetic blood sugar control and overall overall systemic health, and weigh that against the development of wet macular degeneration. So again, that risk ultimately was a 0.2% risk. We're less than 1% risk. So those are tiny numbers. And to make things even more confusing, this is a paper that it's about to be published. It was accepted already a few weeks ago, but going to be published by the American Academy of Ophthalmology. And that's coming out this month. It has not yet been published. So you guys are getting a sneak peek into all of this. GLP-1 medications might actually lower the risk of wet macular degeneration and lower the risk of getting dry macular degeneration. Well, Dr. Kim, how the heck is this possible? Yeah, I'm equally confused. Again, this is very tricky. These are associations. So we're looking at population statistics. We're not looking at exactly cause and effect. So depending on what group of patients that we happen to be studying and how we study it will throw off our statistics and can be very easily, these statistics can be very easily manipulated. So right now, it's very difficult to know what this means. Their studies are done very differently. For the first thing is the one on the left, this green article. This was a big paper done, a large study with thousands of patients, 46,000 patients plus. That was done in Canada. And this one, American Academy of Ophthalmology, was done in America. Now, I don't see a whole heck of a lot of difference between the two countries as far as demographics, and it doesn't seem to be on their data as far as demographics or diet. Potentially sun exposure, potentially smoking. There may be some other lifestyle things. I'm not so familiar with that difference, but there are certainly differences in populations. Also, we have to remember that some of these studies were done based on non-ophthalmologists' data too. So sometimes when we have a Canadian system of health and the American system of health too, actually in both of these papers, we included additional doctors who are not ophthalmologists who might also be diagnosing these things or carrying over diagnoses or using these as referral diagnoses. So there's a lot of intricacies here that can confound our data here. So as of this time, I don't know what to tell you about macular degeneration. I can tell you that the risk is overall low. If there is something there, it's going to be low. It might be better. I don't know. But something that certainly, I have a feeling the media is going to have a field day with this, and you're going to get a lot of conflicting data here, but you're seeing it here first. When we really drill it down, it's going to be hard to compare. These are not apples to apples. And so it's really hard to draw any conclusions about macular degeneration in diabetes. So So the takeaway points here for the GLP-1 medications, I really like to divide this into two subgroups of people. The people who have diabetes, it's, in my opinion, yes, it's worth an evaluation by your ophthalmologist or optometrist. Just definitely, we want to know what your baseline eye health is. But for me, by and large, the health risks and the health benefits overall hugely outweigh any ocular side effects. Even the worsening of the diabetic retinopathy, we can usually treat most of that as long as we keep close eye on it. Just please keep your eye doctor or retina specialist involved with that. But for diabetics, huge benefit for these GLP-1 medications, and I would say that's sort of the no-brainer. The second group of people are the people who are using it, like the celebrities who are using it for weight loss or vanity, or these quote unquote longevity people. 3 to 5 years of being out, I don't know how people can claim that this is a longevity medication quite yet. That doesn't seem like it's long enough to prove that, just based on logic. But I don't know where people are coming up with these, but I would say it's probably worth discussing with your ophthalmologist or optometrist what their thoughts are, or what they think the risk is. And keep in mind that a lot of this data is still very mercurial. This is still data that's fluid and currently constantly changing. So again, even for me as a subspecialist ophthalmologist, it's still difficult for me to really decipher the data as to which study overpowers which study, and which is the better, quote unquote, better data. I think overall we're dealing with very small numbers here, so we really have to weigh the risk and the benefit. Of course, if the risk is pretty minuscule at baseline for you, and this is going to jump up increase our risk a little bit for developing strokes in the optic nerve, or developing macular degeneration. You have a strong family history of macular degeneration, for example, maybe we think twice about the GLP-1 medications. We really try to weigh the risks and the benefits here. So worth a discussion. So also, remember the studies that we presented here tonight. These are some of the main ones that have come out. They're mostly done in diabetics. We don't have enough time. We haven't had enough studies or clinical trials for people who use it cosmetically, people who seemingly have no medical risk or are otherwise healthy, for example. We don't really know what kind of risk increase these medications confer. Also, keep in mind that these are associations. These are not necessarily causative. For a causative kind of study, we would actually have to watch people prospectively, is what we call it, meaning we'd have to enroll people and then start them on a medication and watch them and see, do they develop strokes in the eye, or do they develop macular degeneration? And those are not easy studies to do. So I'm not expecting to see too many of those anytime soon. But the more data that comes out with associations, the stronger of the feeling that we have that they might actually be causal in some way. So pretty early to know exactly. So we're still trying to figure this out. So, and again, for those who like to do their own research, yes, please just take all these numbers and statistics with a grain of salt. The risk overall, I think, is low, and I think but we should all be aware of them. Prescription medications are prescription for a reason, and that's because they are not 100%. They're not fully safe to take. By and large, they do come with side effects or unknown side effects, and that's one of the reasons that these are currently prescription only. So thank you everybody for attending tonight. I'm happy to take questions if you have any.
We do have one, Dr. Kim.
Sure.
They're asking if they have pre-diabetes and intermediate stage dry AMD, Their doctor wants them to start on Manjaro. Should they stay away from the GLP-1?
That's a good question. And this is the exact kind of question that would probably, yeah, we would want to take a look and actually see what the risk is at in the office. You may want to talk to your retina specialist about this, or ophthalmologist about it. I would say overall the risk is probably quite low for developing wet macular degeneration. If we have two very large studies that are conflicting with one another, it's most likely because they just happen to get a sample size that happen to be lean more in one direction than the other. So I think your overall risk is low. Pre-diabetes, we want to, of course, determine what your risk is for developing full diabetes. What other considerations do we need to take into account? Are we overweight? Are there other risk factors like do we have a propensity to have kidney damage, heart damage, a stroke, or heart attack, a possible family history? So there's a lot that goes into this. But I would say, by and large, if we're taking it for medical reasons, like diabetes, or pre-diabetes, or severe obesity, where we start to have high risk for health considerations, I would say overall GLP-1 medications, probably the benefit outweighs the risk. So in most cases, but certainly worth a discussion though. Good question. Yeah. Honestly, I don't know if we have a general answer for that yet. I think it's going to be more of an individual assessment as to how you feel about your risk overall. So, but but yeah, great question. That falls into the gray area in my book. So
And we have another one, Dr. Kim. Thank you for that.
sure.
It says, from those studies, were there any hypotheses made to explain how GLP-1 medications are affecting the retina from either study, either explaining the increased or decreased risk for AMD?
Yeah, both presented or postulated different mechanisms as to why they might see that. So, one being that when we activate the GLP-1 receptor, we see an uptick in another biochemical, one which starts with a C, and it's something that's new to me. So I forgive me for not being able to recite it here, but it's a CXTL something, or something like that. But it's basically a what we call an angiogenesis, or an inflammatory marker. So once we increase the inflammation and the propensity to increase blood vessel growth by activating the GLP-1 receptors, that's usually a good thing, but not a good thing in macular degeneration. Increasing blood flow to certain areas is usually good, but if we have abnormal blood flow to the center of the retina, we can have damage. So that was the theory behind the increased risk of neovascular or wet macular degeneration. In the other article, conversely, these GLP-1 medications also reduce inflammation. They reduce what we call adiposity, so meaning the amount of lipid storage in our bodies, um, and blood sugar control. And all of these things are very closely linked to diabetes. So I'm sorry, to macular degeneration. One of the ways that we think macular degeneration comes about is low-grade inflammation into the retinal cells, or the cells around the retina, and lipid deposits, so fatty deposits under the retina that start to disrupt the metabolism. So once we start to get better control of these blood sugars, blood fats, and high cholesterol, reduce the weight. Those are all helping the risk factors, or reducing the risk for developing macular degeneration. So I can see it in both ways. It's really tricky to know, and I have a feeling there's going to be there are going to be some nuances here. As far as what stage people are starting at, how much what we call ischemia, so how much damage has been done, how much restriction, the circulation has been compromised in the eyes. I think we're going to start to see that pan out over the next, it's probably going to take a while, 10, 20 years. But depending on what stage. Right now, GLP-1s, they're starting to be used earlier on, as we talk, as the last person who had asked that question, now in pre-diabetes. But historically, over the past few years, GLP-1s have been reserved for the most severe cases. And that's another confounder, is we're taking these people and looking at studies for the most severe cases, the people who have the highest risk of having heart attack and stroke, and comparing them with approximate equivalents in people populations. So, but by and large, these people are sicker. Let me put it that way. These people are sicker. So being able to extrapolate data for people who are not quite as sick is going to be a little bit of a challenge based on the current data that we have. As more and more people who are healthier or have milder disease start to be put on these GLP-1 medications, I think we'll have a much better idea as to what that risk is in time. But yeah, right now we have justification for both scenarios, and this is why I think it's a little bit nuanced. And it's the answer. The ultimate answer is going to be very finely nuanced. So I don't know. I don't have a good answer for you at this time. So we'll see. We'll see. Great question though.
And then last one here, Dr. Kim, it says, any known risk for developing geographic atrophy?
Not actually, we did not see that. Interestingly enough, there was a reduction in the geographic atrophy onset. So if I go back to here, there was a 30% in that one study on the right here. There was a 30% lower risk of developing dry macular degeneration in diabetes, but we did not see any increased risk of going on to geographic atrophy. Good question.
Yeah.
Wow, we've got some really educated, high-level questions here. I don't know if I was prepared for this.
Yeah, there's some great ones, but it looks like, yeah, it looks like that's all for the questions.
Great. So wonderful. So yeah, it's really interesting. And I think the second take-home message here is going to be we're going to see a lot of headlines in the news as far as risks, and especially in the eyes. So take it with a grain of salt. Talk it over with your eye doctor and just see, because these medications have been out for long enough now, several years now, that if it were really bad, we should really see a trend now. So what we're talking about is going to be very specific to, I think, your particular case, or it's a very individualized answer going forward. So just be wary and keep an eye out for that. Okay. They are not rainbow. These GLP-1 medications are not all rainbows and unicorns, but and where they don't do any wrong at all. But I think overall, currently, the risk is pretty low. So, all right. So, but thank you everybody for your attention tonight and spending your evening on a very boring topic, learning more when you could be out having dinner and enjoying the summer sunlight. So thank you.
Thank you so much for the wonderful presentation, Dr. Kim. And once again, thank you to all of our guests who attended. If you do have any additional questions, please feel free to email us at marketing@harvardeye.com. But we hope to see you at our next webinar event, and have a great evening.